Hola, buenas noches. Muy bienvenidos a nuestro segundo webinar del año 2024. Estoy muy contenta de estar hoy con ustedes y con una querida amiga que es Regina Hooley. Eh, lo que les quería decir es que Carla Darraz va a dirigir esta reunión y ella va a presentar a nuestra invitada y además les va a dar algunas como se dice, avisos para CIVIN. Eh, como estamos muy bien en la hora, creo que podríamos empezar, Carla. Y antes
Súper,
que, perdón, una cosa muy, muy importante que tengo que agradecer el auspicio de Valle y que nos hayan prestado la plataforma para poder llevar a cabo este webinar. Así que muy agradecidos a Valle como siempre.
súper. Gracias, Marce. Hola, buenas noches a todos. Tenemos un buen número de participantes y estamos justos en la hora, así que vamos a dar inicio a nuestro segundo webinar de este año. Tenemos el placer de contar con la doctora Regina Hooley. Todos la conocemos, sabemos que una referente mundial para nosotros en el campo de las imágenes mamarias. Ella es profesora de la División de Imágenes Mamarias de Radiología en Yale y además es vicepresidenta de Asuntos Clínicos. Así que nos va a hablar hoy día del nuevo Bi-Rads en ecografía. Ella ha estado participando activamente de esta actualización, por lo tanto vamos a tener información de primera mano. Dr. Hooley, thank you very much for joining us today with your presentation. It's a big pleasure for us to have you here. So we are very honored and we are very happy to hear from you directly this topic about the new Bi-Rads in ultrasound. So if we can start, maybe you can share your screen, please, to start the presentation.
Okay, let's see here. All right, so let's just get this in. There you go. How does that look? Does that look good?
Yes, I'm very, very sorry. Just a quick, I forgot to tell the audience that if you have questions, perdón, me olvidé decir a los asistentes que si tienen preguntas, por favor, escribir la cajita para preguntas y respuestas para que las podamos leer después. So the audience is going to write down the questions and we will read them after you finish your class.
Okay, thank you
Please,
very much.
please go ahead, Doctor.
Okay, thank you very much, Dr. Darras. It's really a pleasure to be here and an honor to be invited to present to your group. I wish I could speak another language besides English, Spanish, Portuguese, whatever, but I will do my best to speak clearly so that I hope you understand. And yes, please write down your questions and we'll have plenty of time afterwards. So a hot topic in ultrasound, of course, is the new Bi-Rads. We have been working on the Bi-Rads update, which usually is updated every 10 years for the past several years. But as we all know, breast imaging has become more complicated. We have much more multimodality imaging, and we are very involved in our clinics with our patients. And there's lots of different treatments now and treatment follow-ups and more that we can do. So all of breast imaging, particularly mammo, MRI, and ultrasound, which is all part of the Bi-Rads, is more complicated. And I think that reflects the fact that I don't know if any of you, most of you probably don't remember, the first Bi-Rads that came out was very thin, maybe it was 100 pages back in 1993, 94. And then it got progressively thicker and thicker. And now I think it's much bigger. Of course, we don't print it anymore. And it's being highly vetted by multiple levels by experts throughout the world. So we hope that it'll be out within the next 6 months. It's time. So this is really a sneak peek. These are what I think are the likely updates to be included in the Bi-Rad 6th edition. I was very fortunate to be one of the co-authors of the ultrasound portion, led by our committee chair and fearless fun leader, Jessica Leung, and then also Dr. Baker, Loving, and Rapelia also contributed. So we worked together and went through the 5th edition of ultrasound and made our updates and then presented it. And then Jessica has presented it to the next Bi-Rads committee to make sure that it all matches and makes sense. So that's where we are now. So we'll see what the final edition will state, but this is what we wrote and have, proposed. So just to review, the Bi-Rads 5th edition, of course, has a lot of terminology. The focus is on the lexicon as well as management. It's really focused on quality and safety. And look at the success of the Bi-Rads that has been cited by close to 3,000 publications. It's been in use for 31 years and translated into 8 languages. It's quite amazing, the success of the Bi-Rads. And again, the first Bi-Rads was published back in 1993-94, and nobody cared really that much about it except for the breast imagers and our other colleagues and radiologists and the subspecialties, clinicians, radiologists, and leaders didn't really care until probably the last 5 or 10 years. And of course, now we have ThyRads, LIRADs, PIRADs, every kind of RADs because of the structured reporting and the data analytics that are capable, that are available when you do structured reporting. So we are really leaders in the field, having been doing this for so many years and have an advanced lexicon and reporting system. So as far as ultrasound goes, we have proposed changes and updates to the areas that are starred. So I'm going to go through them pretty much in order. There's updates in tissue composition, terminology for shape, echo pattern, posterior features, calcification, some of the associated features, and the special cases has also been expanded. All right, so let's talk a little bit about tissue composition, which in the 5th edition, we have the tissue pattern, and that's going to stay the same, where you can add homogeneous background fat, homogeneous background ecotexture fibroglandular, or heterogeneous background ecotexture. In the 5th edition, it was proposed that this tissue pattern be specific to screening, and that may be removed in the 6th edition. That said, we are also introducing the glandular tissue, the glandular tissue component, which is also known as fibroglandular component, as a subcategory of tissue composition. And that's because there has been work, particularly done by the group at Seoul National University, led by Dr. Moon in South Korea, that shows that ultrasound can distinguish glandular tissue from the fibrous tissue. And it is an ultrasound correlate to mammographic density and MRI background parenchymal enhancement because this GTC has been shown to be now associated with risk. And interestingly, or not coincidentally, I'm sure, it's classified also as minimal, mild, moderate, and marked. So very similar in parallel to MRI and also similar to mammography. So what are we talking about? So this is a landmark paper published in 2001 by Dr. Moon and colleagues, looking at the glandular tissue component relative to the fibrous stroma, showing that, the fibroglandular tissue can be assessed as gray and white areas on ultrasound. And what we see, we always see this on ultrasound, particularly if you do a lot of screening ultrasound, that underneath the subcutaneous fat layer, you have this ridge of fibroglandular tissue that's above the retroglandular fat and above the pectoralis muscle. The retroglandular fat is often very thin because we're pushing down. And in women with a transducer, and in women with dense breast tissue, which is, we often do that particularly in screening ultrasound, we see this layer of predominantly echogenic tissue, but the pattern can be quite different. And so Dr. Moon and colleagues looked at the anatomy and showed that these hypoechoic areas really reflect the lobules. and which are the more prominent part, as well as some of the terminal ductal unit, and the white part is the interlobular stroma. So we're classifying this as minimal, mild, moderate, and marked based on quartiles. Again, similar to mammographic density, but you can also see the difference as well. They did work on this. And so in this paper, they looked at 233 women who had a benign biopsy within 1 month of screening ultrasound. And they looked at the lobular involution on pathology and showed that there was complete, moderate, and mild or not present, meaning that there was a lot of lobules in this range, 9%, 44%, 37%, and about 10%. So again, very similar to breast density, although in these women, the distribution is very similar to breast density. So they found that women with a high glandular tissue component frequently had no or mild lobular involution, meaning that they had that heterogeneous pattern on the ultrasound itself. So here is the corresponding pathology, and this kind of looks, if you can think of these as hypoechoic spaces, and the pink is the stroma, because the glandular tissue is replaced by stroma. This is the echogenic tissue that we see on ultrasound. He also showed that this glandular tissue component can change over time. It's not static. So in these women, when they had follow-up ultrasound, there was some shift in the way their breast parenchyma looked. And not sure if that was age-related or related, also probably related to age, or a little bit of hormones as well. So interestingly as well, they also showed that the low glandular tissue component in blue was not as associated with risk of breast cancer compared to over time, compared to those with the higher glandular tissue component. You can't tell by the mammogram. The mammogram, is you can see that these women, 4 separate women, have dense breast tissue, different patterns, but still just dense based on mammography. But the ultrasound tissue pattern is very distinct, particularly here where there's a lot of glandular involution and lots of stroma, a few little hypoechoic areas, and those are the lobules, so more of a mild pattern. And these are probably moderate here, these 2 patterns where it's, I don't know if we're going to be sticking with percentiles. We don't mention that in the new Bi-Rads, but that in the paper they mention the 50 to 75th percent for the moderate GTC. And here's just more patterns. Here's a more marked pattern, and we see that. I don't know how much screening ultrasound you do, but even in a targeted ultrasound, when you see this tissue pattern, it's very busy. You don't know what's going on. It's harder to read versus something like this where it's very easy and you can call it all normal and it's just simpler. And subsequent studies have shown as well that the false positive rates are much higher with this tissue component as well. And the sensitivity is also decreased. And that's really predominantly by Dr. Moon's work, which is really, I think, quite impressive. He published just last year looking at breast density and comparing, and this is a nice paper because it looks at multiple imaging modalities, but with ultrasound, focusing on ultrasound, he's showing that, the glandular tissue component here is associated with a higher abnormal interpretation rate and associated with increased risk, as opposed to just plain old tissue composition the way the old Bi-Rads was. So that's why we hope to include it. I think it will be included in the new Bi-Rads. So I think that will be interesting to learn more as well, and how that's going to affect the care for our patients. And it's also good as far as AI and radiomics in the future, and more correlation with ultrasound, mammo, and MRI, and looking at tissue patterns and breast complexity will be interesting. So it'll be good to, I think, to include that, or at least, at the very least, be aware of it. Remember, the Bi-Rads is optional terminology for the most part, but the more we include this in, the more we will learn in the future, because we'll have that database in our reports when we pull it out, and hopefully have AI look at it, or or other researchers. Okay, so let's move on now to masses and shape. There's going to be an update in the shape. Lobular is back. It took a rest, it was retired, and now it's back. And that's because we feel that lobular is really more suspicious than oval and higher PPV. So we still have round and we still have oval and irregular, but lobular is a distinct shape. And before we would probably just put lobular in with oval, but now we know that a lot of oval masses are benign, but lobular not so much. So that's going to help with our accuracy, because the nice thing about Bi-Rads is when you use a terminology, it can help you better determine your management and how you're going to assess a lesion. So that's what that is. So remember, there's still going to be microlobular margins. So sometimes there can be some overlap. Here's a small little microlobulated margin. We always worry still about the most worrisome finding on Bi-Rads, the most worrisome descriptor, sort of like negates all of any other benign descriptors. But so even though you can say this is lobular or is this angular, you need to use your judgment. You look at other factors. There's some indistinct margins. This is really more irregular. And here's a lobular, which was a cancer, has some cystic components as well. So lobular should be back. As far as the echo pattern goes, we have proposed that complex cystic and solid mass be replaced by mixed solid and cystic. And that's because it's really the solid component that's important, and that complex cyst terminology has always been confusing. So we see people using in breast imaging complex cyst. We know that complex cyst is okay terminology in the rest of the body, but Bi-Rads has always, the last few editions has taught us not to use complex cyst, to use complicated cyst, and then complex cystic and solid. But it's confusing, right? Even as I'm describing it now, even though most of us are well versed in it, it's very confusing. So hopefully the mixed solid and cystic will be a little bit clearer, and it really more accurately describes what's going on. And again, it's that solid component, whether it's a thickened wall or a mural nodule, that's most important for these masses. And here are just some examples where they look like cysts, but there's something going on, whether it's debris or a solid component. This also turned out to be debris, or something that's has a thickened wall. This one was the cancer, not surprising. As far as the posterior features, mixed may also be retired, because who cares whether it's mixed? It's the shadowing that's the most important feature. So certainly you could have a mass with really no posterior features, and this one blends in. You can have enhanced. You turn off, especially for cysts, and when you turn off your harmonics, when you turn off your compound imaging, that can pop out. So that's what we do. So this is an enhanced. But when we have the shadowing, that's suspicious. And in this case, does it really matter that it's mixed? It's the shadowing, again, that's the most important component. So we're proposing that mixed be retired just for simplicity. This is, I think, an important new feature and an interesting new feature, and that's the focus on the echogenic rind, which is the thick echogenic band that we can see surrounding a mass. And that's a worrisome finding in general, and also reintroducing the pseudocapsule, which is that thin surrounding band, like pencil-like thin surrounding band. This is described by Tom Savros, I think first in a paper in 1995 that was published in Radiology, that pseudocapsule indicating a benign finding, and it has to be around just about the entire mass. Knowing that sometimes with ultrasound, the lateral resolution is not as sharp as the anterior and posterior, so you might lose a little bit on the lateral edges of the mass. So the associated echogenic rind has been shown to be predictive of malignancy. So a couple studies, there was 45 triple negative cancers, and 2/3 of them had an echogenic rind. Another study showed that the echogenic rind had a positive predictive value of 86%. Now remember, they probably weren't calling it echogenic rind. It's been called echogenic halo, echogenic rim, but we thought halo sounded too good, right? Because it sort of indicates something that it's well behaved, and we know that this is an echogenic rind, tends to be associated with malignancy, and the rim is too close to a pseudocapsule. So we decided on echogenic rind. So hopefully it will be included in the Bi-Rads, the new Bi-Rads. And remember, when you see this echogenic rind, you should include the rind in the mass measurements, because there's been studies that show that it's more predictive of pathologic size. I think it'll be interesting when this comes out. It'll be some interesting studies if somebody's looking for a new study, because it's always good to replicate studies across institutions to really look at what is in that echogenic rind and how it really, these are small studies that looked at it, but really to show what the echogenic rind indicates. I think it's variable. It's usually some desmoplastic reaction or edema, but it'll be interesting to learn more about what that echogenic rind means. So these are all cancers with variable echogenic rinds, even this little tiny one when you start seeing it. And again, we have to teach I know I have to teach my techs to measure this rind, because they tend to only measure the hyperechoic part, but it should be. And so here's an example of, the measurement, and then we had our tech measure it appropriately. And you have to correlate it with the mammography and clinical correlation. In this case, this was a benign fat necrosis. So they're not always malignant, but it is associated with malignancy. So echogenic rind, hopefully that'll be in there. The pseudocapsule is typically associated with benign, as I meant, or oval and round masses, as I mentioned. It has to be visible around the entire portion of the mass, so it's like pencil thin line. Again, the lateral part may not be as sharp, but that's okay, because ultrasound is not as good at lateral resolution as it is anterior-posterior. So you can see here. So these are all nice examples, and this is usually associated with a benign finding, usually fibroadenomas for the most part. It has to be complete. So here is a nice little thin line, but then this is too ratty, right? And when you turn on it, it's indistinct. And this was, a little cancer as well. Okay. Oops. Yeah. All right. Okay. What about calcifications? We can have calcifications right now in the Bi-Rads. It's the calcifications are described inside or outside a mass, or intraductal calcifications as well. And we're proposing that they be replaced by micro and macro calcifications, which we can see on ultrasound. Macro calcifications, are large. They shadow. They're associated with fibroadenomas, fat necrosis, just larger, obvious ones. They can mimic the appearance of a mass if they're big. And the microcalcifications are just a little smaller echogenic foci. Should we use foci in the Bi-Rads? No, except for that for ultrasound. But it's still used in the literature, and in recent published literature, people are describing that. So again, we'll see about foci and how that plays out in the Bi-Rads. I heard it might be retired for MRI, but I'm not sure. Because I haven't read the MRI, but that's just what I've heard. Okay, so again, macrocalcifications can present as a mass, or they can mimic a mass here. Here's a large macrocalcification on ultrasound, on mammo, and here's the ultrasound. If you didn't have the correlate, you might think this is a cancer. But this color Doppler doesn't really help. It looks like there's flow in this spot, but it's not flow. It's a twinkle artifact with a flash in red and blue in real time. If you have if you can pulse it with pulse Doppler, if you have that capability on your ultrasound machine, you'll just see noise. You won't get a real wave. In our practice, we don't have the pulse Doppler feature in breast imaging. We don't, general body ultrasound has it on theirs, but we have never gotten it on our ultrasound machines. But you can tell the flash anyway, and you're all correlating it with a mammogram as well, so we don't need it. DCIS on on ultrasound can be seen. You know, the more extensive the calcifications, the more likely you are to see it on ultrasound. I like doing it because it can help identify the invasive component. You know, a mammogram like this needs to be the calcifications need to be biopsied. These are a Bi-Rads 5, maybe a 4C, probably a 5. But if you do a stereo, you're just going to pick some random calcifications. You're not quite sure. But when you do the ultrasound, you can see the calcifications and you can see them in sort of a segmental or ductal distribution. But you can also pick where the duct is breaking, that, you know, where there's like a disruption. And that's going to increase your sensitivity on biopsy because you'll be more likely to get the invasive component when you do the biopsy. So that's what we like to do. And not to mention that the ultrasound guided biopsy is faster for the radiologist and the patient, and is also more comfortable for the patient. So that's always our biopsy method of choice. Here's another case where we have benign calcifications. This patient was recalled from screening with some unilateral calcifications on her baseline mammogram. And you can see in the ducts here, these little echogenic foci. I'll call it foci for now because I just read an article before this talk published by Dr. Moon. I thought I included it in here. It might show up later. Dr. Moon in Seoul National University, you know, really a pioneer in breast ultrasound, and he just published a paper this year, 2024, and he was describing foci for non-mass lesions. Anyway, so I'll call it foci for now, but that's really not in the Bi-Rads. These little echogenic dots, I don't know, echogenic calcifications. So with optimal technique, you can see some, but not all microcalcifications on ultrasound. It helps when there's hypoechoic tissue around it. So for ultrasound calcifications, it's easier to visualize malignant calcifications. It's generally easier to visualize high-grade DCIS, particularly if there's microinvasion. Certainly in small breasts, and if the calcifications are superior and anterior, it's much easier to identify them as opposed to deep posterior. Larger, segmental, and malignant fine linear branching calcifications are also more likely to be visualized on ultrasound. Here's just another case of some fine microcalcifications on mammography. And we didn't think, she had very thin breasts and it was in a difficult location. We thought doing stereo might be hard, particularly with a prone stereo table. And so we did the ultrasound and we found this predominantly hyperechoic mass with some echogenic areas in there. Maybe that's a non-mass lesion. We put a BB to see if it matched, and we thought it was a close enough match. We put a BB on her skin because we weren't sure at the time whether this was real. So we like to use that BB trick where we put the BB on the skin under ultrasound and we do the mammogram. It's rare for it to match perfectly because the BB's on the skin in a different position and not on the actual lesion itself. So this was a close enough match, and we did the biopsy, and this was ultimately turned out to be a very small infiltrating ductal cancer, originally ADH. And there are some of the calcifications that we got on the ultrasound for biopsy. Benign calcifications, clips and markers, they can mimic, right, with that twinkle artifact as well. Okay. Let's talk a little bit about lymph nodes. We're going to shift gears now from masses and microcalcifications to lymph nodes because this area has been expanded. There's been a lot of work over the last, let's see, maybe 15 years or so, almost 15 years, with axillary lymph nodes, with the Z11 trial, looking at sentinel lymph node biopsies and whether or not we should be looking at the axillary lymph nodes in patients with newly diagnosed breast cancer. Generally, I think the answer is yes, we should do that. At first, there was some debate, but we do. And as radiologists, that's what we want to have the most information for our patients. So it's been expanded, and it's going to include intramammary, axillary level 1, 2, and 3, internal mammary, and even supraclavicular will be optionally reported in the Nuevo Bi-Rads. So remember that normal lymph nodes tend to be reniform in shape, hypoechoic, thin cortex. Size is not a useful criteria. We know that in the axilla, in particular, lymph nodes can be quite large, and as long as they have a nice fatty hilum and a thin cortex, that's fine. And this central vascularity is always helpful, right? We get hilar flow, which is normal. Abnormal lymph nodes have focal or diffuse cortical thickening greater than 3 to 4 millimeters, a round shape. The hilum is sort of pushed away, and it's eccentric, or it might be completely replaced. There can be disorganized peripheral flow, which I think is a very sensitive marker for malignancy, because normal reactive lymph nodes will not have neovascularity in the cortex. Again, more abnormal lymph nodes, they can look very cystic. You shouldn't have cysts in the axilla. And this disorganized flow, again, is abnormal. We know that benign reactive nodes can mimic malignancy. This is an interesting case, a 22-year-old with right axillary pain and history of immune deficiency. She was sent to us to biopsy this abnormal lymph node. The hilum is pushed off to the side. She was unilateral. We scanned the left side, but was wondering, well, how, 22-year-old with, breast cancer presenting with an axillary lymph node. It's possible, but this is my colleague. She scanned it and thought that, maybe it was a little bit smaller, and because it was referred to us from the outside, took that history of immunodeficiency and decided to defer the biopsy. And so the patient returned 2 weeks later and thought again it was slightly smaller. And we confirmed that the patient ultimately had cat scratch fever. And so she didn't need the biopsy, and this completely resolved over time. So anyway, sometimes these benign reactive lymph nodes can mimic cancer, but you do have to be very careful with these. So as far as the positioning goes, we need to pay more attention to this. I know our breast surgeons want to know where these lymph nodes are, particularly in the setting of neoadjuvant treatment when they're following the patients and they're really mapping things out and want to know exactly what they need to do as they're monitoring the patients and planning their surgery over time after treatment. So the 3 levels of the axillary nodes are defined in the relationship to the pectoralis minor muscle. And level 1 are lateral or inferior, and I'll show you some example. And that also includes intramammary nodes in the upper outer quadrant, okay? Level 2 are posterior to the pectoralis minor, and the Rodder's node is an interesting node that's between the pectoralis minor and major. And level 3, which we rarely see on mammo and ultrasound and even MRI for most of our patients, because it's usually not advanced. Those are medial to the pectoralis muscle with infraclavicular nodes. So it's progressive and has worse prognosis, particularly if you have level 3. So that's because the normal drainage generally proceeds from level 1 to 3 and then into the thorax. Level 1 and 2, fortunately, have generally the same impact on prognosis, but 3 is worse. But the surgeons still want to know where they are. So that's a change, I would say, over the last year or two, where our surgeons at Tumor Board want to know exactly, particularly on MRI, where the lymph nodes are located and if they're a level 2. So it's not good enough for us to say there's abnormal axillary lymph nodes. They want to know if it's a level 1 or level 2, or if it's close, if it's a far sort of a posterior lateral level 1 that's like creeping up to be behind the pec minor. Anyways, so on MRI, I think we see the axillary nodes the best. Pec major, pec minor, these are level 1s, more level 1s here. On mammo and ultrasound, these are most of the time we see level 1s. I think it can be hard to determine the level 2s on ultrasound, and I think as we start looking more, particularly with the help of the Bi-Rads, we'll be able to determine more of these. But when they're deeper, that's the case. So here's level 1 and level 2 with a correlate with the MRI. This is I think our surgeons counted this as a level 2 because it's kind of right back there. And that's what we see here as a level 2. This is an abnormal level 2 lymph node because the patient had an axillary node dissection, and you can see that it is actually behind the pectoralis and deep there. So this is level 2, and she had a recurrence. Just for interest, I don't have an ultrasound correlate, and I don't know how well you can see this, but this is a deep level 2 here as well. Okay, not to be confused with sometimes you have the vessels going back behind the pec minor here, but this one was separate from the vessel, and she had some abnormal level 1s too. Internal mammary nodes typically occurs after metastases to the axillary nodes, or can be more associated with medial breast lesions, because sometimes the internal mammary nodes can be the sentinel node, particularly for medial and posterior lesions. There's really no survival benefit. I mean, it's hard to biopsy these internal mammary nodes, and it's hard to surgically remove them, so dissection is usually not performed. Our surgeons don't really care about these nodes. I mean, they like, if it's abnormal, they want to know about it, and that would be seen on MRI. They feel that the radiation will generally treat these nodes, okay? But it does still impact some staging and prognosis, but we don't biopsy them, but the group at MD Anderson does. They do FNA. Which is great, and it's a skill. It takes a little bit of practice, but this is from Bruno Fernage, his article on how they would do an FNA for these internal mammary nodes, and here's an MRI with an abnormal internal mammary node. Supraclavicular nodes, consider looking for them. If there are lots of axillary lymph nodes, you can see them on ultrasound. You can do a biopsy of them. In general, in our department, interventional radiology biopsies these supraclavicular lymph nodes. They can be safely done in the in breast imaging, but generally they're not done anymore. And I say it's safely done. This is one that I did a while. This is an old case where we were asked, and we were able to do it and watch the tip carefully and biopsy with a 16 gauge needle the supraclavicular lymph node. But you have to be very careful. So IR does it, and that's totally fine, you know. Okay. All right. So now on to a hot topic, and that is the non-breast lesion. And that, I think, is one of the more interesting new additions to the breast ultrasound Bi-Rads. And so we know that there are abnormalities, including cancers in the breast, that do not conform to a mass or shape. And in mammo, we have asymmetries, and in MRI, we have non-mass enhancement. But ultrasound, we really don't have anything, right? In the Bi-Rads, there is nothing. But yet, you know, we have some calcifications and architectural distortion and duct changes, but nothing else. And in fact, non-mass findings or non-mass lesion, non-mass areas has been reported in the literature for many years. And the terminology is quite variable. So I think that the ultrasound Bi-Rads, last I heard, it doesn't really matter, but the last I heard, it's going to be a non-mass lesion versus a non-mass finding. But in any case, we are going to have a non-mass descriptor in ultrasound. And we know that with advances of equipment and breast ultrasound skill and knowledge, we're seeing these little fine abnormalities that don't meet the criteria of the mass, right? We see things more because we're better, we have better equipment. A mass is a space-occupying lesion seen in two planes. A non-mass finding may not have a definite shape. It might be seen better in one plane than the other. There's some disruption of the tissue that we see. It's very subtle. It may or may not have a correlate on mammo or ultrasound or MRI. It can be difficult to accurately measure. So we've seen that before for many years, and now we can actually better define it, I hope, with the new Bi-Rads. One key is that it should be reproducible. Somebody had mentioned to me after hearing a lecture, it wasn't my lecture, but recently, that once they heard about these non-mass lesions, they're seeing it all everywhere. Like in all the normal breast tissue, they're seeing non-mass findings. Remember, it has to be distinct from the surrounding breast tissue. It has to be reproducible. And we also know it doesn't conform to a mass shape and lacks the 3D dimension of a mass. For many years, when I'm not quite sure something is real or not, what I do is I stop, and these are small things, right? But sometimes you can have non-mass findings that are large, but for smaller things, I'm not sure. I stop and I take my hand, because I do a lot of scanning myself. I stop and I lift the transducer up and I just chat for a few minutes, not even a few minutes, 30 seconds with a patient, right? Or just say something. And then I go back. And if I can find it again, right? Maybe I might do that 2 or 3 times. Then I think it's real. But if I can't find it again, then I know my colleagues aren't going to find it if she comes back for a biopsy or whatever she comes back for and I'm not there. So that's my trick. And so it has to be reproducible. If it's not reproducible for the original person who found it, it's not going to be reproducible for other people. It's pretty uncommon. Probably the incidence is less than 5%. And although it may not always have a mammo or MR correlate, it should have some correlate, including either a physical exam, because otherwise we will start seeing them everywhere. I think it's hard to call a non-mass finding alone on a screening ultrasound unless it's really distinct and large. It generally should have some correlate. All right, so here's an example. Is this an architectural distortion, an irregular mass? This is a 47-year-old with a screening detected cancer. It is a judgment call on some of these things in the Bi-Rads. Some items in any modality, and from the Bi-Rads from the first edition to now, sometimes there's a judgment call. But this could be considered a non-mass finding, and some people have reported that architectural distortions should be included as a non-mass finding, although I think in the new Bi-Rads, we kept it separate, but that might change. I think that that's up for debate. Again, variable terminology in the literature, hypoechoic area, could be ductal or non-ductal, it could be a non-mass lesion, non-mass-like lesion. There's all these things, right? But it should be distinct, and heterogeneous tissue alone does not meet the definition of a non-mass. It needs to be distinct. Again, here's just a review of the literature from years. Again, lots of publications, and this was published, this is a review, in 2020 in Radiographics. So these articles are relatively old, and again, slightly variable terminology. So we're trying to pull that together to make it more consistent, right? So that we're all using similar, or start using more similar terminology and descriptors. So descriptors include echogenicity. It can be hypoechoic, hyper, mixed, or anechoic, or even isoechoic. Distribution can be focal, linear, segmental, or regional. Can also sometimes be large and global. And there can be some associated features, but shape and margin are not descriptors. Here's the recent publication that I had alluded to earlier by Dr. Moon and his colleague. So this is February of 2024, showing that a non-mass lesion can be associated with calcifications, distortion, duct changes, posterior features, vascularity, and elasticity. It has to be distinct from normal tissue. It lacks the margination of a mass. It's often subtle and primarily visualized in one plane only versus a mass. So this is something that he's very passionate about, alongside with glandular tissue component. So non-mass lesions are concerning because the malignancy rate is, in the Bi-Rads 4 category in general, 10 to 54%. So as a result, a true non-mass lesion does require biopsy. More often has, if there's a mammographic correlate, of course, malignancy is more likely. And DCIS and infiltrating lobular cancer are more frequent culprits than garden variety infiltrating ductal cancer. It can be benign, and the differential diagnosis is quite long for, the typical sort of garden variety benign stuff that we see on biopsy. So again, with mammo, the correlation, you can have calcifications, a focal or developing asymmetry, architectural distortion. MRI might be a non-mass enhancement or small enhancing masses. This area, it's distinct, but, relatively subtle, easy to miss. With a single plane, a single frame, it's easier to identify, but certainly when you're scanning, it can be a little bit harder. Here's another case of a non-mass finding. Just, is that really a mass? It was distinct, echogenic, had a little cyst in there, 36-year-old with breast tenderness. Here's her mammogram. And we thought this could be a hematoma or an inflammatory lesion, but it resolved on follow-up. So again, this is just something that was very distinct, but didn't really match the criteria for a mass. Had some flow around it. Associated findings, if you have small cysts, that has been reported to be associated with benignity. But if you have a mammo or MRI correlate, it's more significant and predictive than any ultrasound morphologic feature. But we've also seen it with palpables as well. So here's the paper that shows that small cyst is more likely to be benign. This looks very similar to the case I showed you before with the small little microcalcifications that are associated with layering milk of calcium and fibrocystic changes. Here's another case of a lady with a palpable mass. And I think we're going over time. So anyways, a ridge of glandular tissue, non-mass finding. It looks like tissue, but that is her palpable area is normal tissue. Here's regional, mixed echogenic, just more diffuse, regional. She was status post-reduction surgery with some palpable lump, and we thought this was fat necrosis, but not definitely a mass, right? But it was so non-mass finding it is. Now we know what to call it, right? And it can be regional, it can be, large area as well. So you have those descriptors to use. Post-reduction scarring, scar tissue can do it as well. Stable, looks funny. If you didn't have that history on a normal mammogram, you would be concerned, but more prominent as we scan. This is an interesting case of a 59-year-old who had screening ultrasound. And, the problem with the screening ultrasound is the tech marks a tender area, and that's not never really good. But it looks normal here. And here's another view. She stopped and took an extra picture of it. And here's her mammogram, which was normal. It was thought to be normal as well, but she did come back 6 months later with a palp that hadn't really changed. A few months later, 6 months later, and here's the ultrasound with a palpable non-mass area here, even though the mammogram really hadn't changed at all. So anyways, subtle focal hypoechoic non-mass lesion that was palpable. Architectural distortion, we'll have to see, is this a non-mass? Is this an architectural distortion? Is it a non-mass associated with a distortion? I think we'll have to figure out exactly how the new Bi-Rads will sort of chart out where these terms will lie in relationship to each other. As far as I know, the architectural distortion is separate, but certainly papers have described that architectural distortion is a subcategory of non-mass. So we'll see. But we're learning more about it. That's the whole point. Now that we're paying attention to it and trying to have a consensus, we're learning more about it. Here's another one. This is a distortion. I'm not even sure. It was called a distortion on tomo, very subtle. And there it is, small, complex, small tubular carcinoma, excuse me, with a radial scar. Duct changes are associated with the non-mass findings as well. It's papilloma and infiltrating ductal cancer. And again, they had these guys came up with this very complicated scoring pattern. I don't think anybody will use it, but they were just showing that, if you have, more duct changes and posterior shadowing, that's more suspicious and it's predictive of malignancy. I think this is too complicated to use in real life, but just shows what to pay attention to. DCIS may present as a non-mass finding as well, so we show that. And again, here's these calcifications. So there's a little bit of overlap again of calcifications, micro calcifications associated with non-mass findings, but that also reflects what we know on the mammogram. Here's a patient with bilateral global distortions. She came in for screening, thought that she told the tech, my breasts are hard, it's because they're changing because of menopause, and just looked abnormal, and it felt abnormal. The tech called it out to me, and she just had this diffuse changes, non-mass findings on her mammogram, and this turned out to be bilateral infiltrating lobular cancer. Similar case, but this was actually, lucky for her, this is diabetic mastopathy in this case. So some overlap, global distortion and global hypoechoic non-mass findings. That's the TOMO. And it's just everywhere. But luckily, this was just mastopathy, and a 27-year-old with also some edema and skin thickening on her left side, big lymph nodes. Here's our MRI. But lucky for her, this was neutrophilic granulomatous mastitis, showing up as diffuse non-mass findings on her ultrasound and this ring-like abnormal enhancement on her MRI. So, you know, with ultrasound and MRI, ultrasound correlate is often vague areas of decreased echogenicity and altered echo texture. So it does correlate with non-mass enhancement on MRI, which is good. You can also see calcifications. So it's nice that we have that now because it correlates with the mammo and ultrasound findings that we've seen. The definition, though, some people don't want it because the definition is ambiguous and we might use it for everything now if they're afraid that everybody's just like the word density, right? Like everything was density on the mammogram and now everything's going to be like these non-mass areas. But so it really should have a correlate on mammo, MRI, or physical exam in general for the most part. Rare cases without, okay? And that's the thing. Is it real? Is it not? Is it a fat lobule? Sometimes it's hard to tell. But that's our judgment. That's why we study these things, and that's where our expertise comes into place. You can have artifact. This was a Bi-Rads 5 lesion described in a woman with dense breasts. We could, from an outside place, we could not reproduce it, and that's because she was not scanned in the semi-oblique position. She had pendulous breasts and was lying flat. And because we asked her, we're like, how are you positioned? We can't find this suspicious mass. And she was like, well, I wasn't in this, you know, I was lying flat. I wasn't tipped up. And so when we turned her flat supine, we could sort of reproduce it. So sometimes you get that. Again, is this real? Is it not? This was real because she had she presented with a palpable mass, and this was her cancer that had metastasized. So I know I went over. Oh, not too bad, 5 minutes. So as far as the updates go, glandular tissue component, we expect to see that as part as a new addition in the tissue composition. So on the first line, mass shape, lobular should be included. The echo pattern should have mixed cystic and solid. We have associated features, echogenic rind and pseudocapsule. Echogenic rind is a change in terminology. Pseudocapsule is being reintroduced. Calcifications, micro and macro, may replace inside and outside a mass. Posterior feature mix should be retired and now is included in shadowing. Well, there's an expanded lymph node section, so start paying attention to those deep nodes in the pectoralis muscle and see if you can really clearly identify the level 2 nodes, and and quiz yourself, because then if you see somebody with a heavy lymph node burden and they're going to have an MRI, you can sort of start to learn and teach yourself if you haven't been looking for those level 2 nodes on ultrasound, which I know we really haven't been distinguishing them. And of course, that non-mass lesion or the non-mass finding. So the final terminology will be determined. I don't even know exactly what's going to be there. I don't know if anybody really does. It's still in progress, but hopefully it will be published in the next 4 to 6 months. That's the hope and the expectations. So thank you very much. This is a rainbow cloud. I was lucky to go to Taos, New Mexico this summer, and we looked up, and who knew such a thing, this is for real, as a rainbow cloud exists. So anyways, so that's it. That's all I have, and happy to answer any questions.
Thank you so much for your presentation, Doctor. It was really amazing to participate. We have some questions in the boxes, so voy
Should I
a leer
stop
la
sharing?
primera.
Should I stop sharing? Is it easier? Yeah.
Okay, yeah, as you wish.
Okay.
Entonces, la primera pregunta dice, ¿cómo se incluiría el componente glandular en el informe? So the question would be, how would the glandular components be included in the report?
I think it should be included in the report as mild, minimal, mild, moderate, and marked glandular tissue component. And the question is, and I've asked this to the Bi-Rads, and we haven't gotten it yet, is if this only applies to women with dense breasts, because the articles published by Dr. Moon are predominantly in women with dense breasts. And so I don't know if it really applies to women with fatty breasts. So that's a question that we should, that hopefully the new Bi-Rads will address. Because we pose that as, there's also the that question and answer part of the Bi-Rad, so we threw that in because and I actually don't know the answer. I actually don't know.
So you are not currently, are you using any of these new terms in your daily practice or not yet?
Oh, I am. In all fairness, my practice has not really used the initial tissue composition pattern. We have not been using that. I think we should. We just switched to a new reporting system, and that is included there. But I do use the echogenic rind. I'm starting to use pseudocapsule. I use almost everything. I would say I use just about everything now, because they're not major differences. The only thing I don't use quite yet is glandular tissue component, and I am going to, I signed up to do a journal club. Yeah, I know it's an old article, but we're starting up journal club, so I'm going to do that. That's the article I'm going to pick because I want people to know about it, because I think it's important to understand what that means, and because it's related to risk. So I'm hoping that and I'm hoping that my group will include it. Like, I like consistency. So I'd like everyone to start using those terms, so that when we do research in the future, it's easier to collect data. That being said, those other terms are easier to implement in your daily practice.
So there are a couple of more questions about the glandular tissue component. So where should be measured? Like how do you choose which quadrant to evaluate? Because it's not the same in all parts of the breast.
Right.
And another question related to this topic is if it relates with the BPE.
Relates to what?
To the BPE. To the background parenchymal enhancement in MRI.
The last question I can answer, I don't think we know that. So I think that we need to, again, those are great areas to do a study on. And I think that would be something that, could be published relatively. There's no paper that's published easily. That's all hard work. But that would be something that would be novel that we wouldn't know. And so when you're the first, when it's something new and it's relevant, then it would make more of an impact and be easier to be published. So I think that would be a great question. Does that make sense? If you're the 10th person to study something that's already been published 9 times, it's harder to publish it, because people will say, well, this is nothing new. But if you're the first one, it's easier to publish. And I think that that's something that needs to be looked at as we learn more. you know? As far as what quadrant, again, that's a very good question as well. I think that, you know, I think that where you see wherever it looks the most prominent would be where you would, what you would say, right? Because that's going to increase your risk. So these are good questions because, again, we don't really know. For screening, it's easy, right? For screening ultrasound, it's easy because you're looking at all four quadrants and you can just look at the worst one and say, and that's how we do breast density too, right? We always look at the worst. She cannot look very dense, but if there's one quadrant that's dense, that's what we base the breast density on. So it would be similar to that. Now, when you're doing targeted ultrasound, that's different because you're just looking at that one area. So the question is that does that glandular tissue component only apply to screening, or does it apply to targeted? I would think that it's going to apply to targeted, and you just in that area that you see, you would mention it. A lot of people don't do screening ultrasound, so.
So, okay, so we have another questions about axillary lymph nodes. La evaluación de los ganglios axilares, si son sospechosos, pueden influir en el B-Rads. So the question is if the evaluation of axillary lymph nodes, if they are suspicious, can it influence the B-Rads assessment?
If the axillary lymph nodes are suspicious, yes, you would include that in the B-Rads assessment, right? Just like in mammography, if you have a suspicious axillary lymph node without a history of lymphoma or something else that explains it. In mammography, if you see an abnormal lymph node on screening, it can be a B-Rads 0 or a B-Rads 2, depending on the clinical history. So I think it's the same. It would be managed the same way. If you had a new diagnosis of breast cancer or a B-Rads 4 or 5 mass and you see an abnormal lymph node, then that's going to be suspicious as well. Does that make sense?
So we have one last question, I think. How are non-mass lesions categorized in the new Bi-Rads?
It's basically non-mass lesion, and it's also, hold on, let me just go back to the slide. You can define it also by distribution, it's going to be by distribution if it's like focal or segmental. It should be that way is what we propose, or global, regional, non-mass areas. And echogenicity will also be included as well, hypoechoic, echogenic, mixed. It's going to be hard to have an isoechoic non-mass lesion, I think, but it will be defined in those terms. We hope, we proposed, right? But there should be. And again, I don't know how architectural distortions are going to be. The last I saw it was separate, but there's an argument that architectural distortions and ductal changes could also be included in that as opposed to being separate. But initially they were separate, but more of the literature is saying it should be included. But I think that in some ways that categorization in the B-Rads is irrelevant, because what you'll say in your report is there's a non-mass lesion associated with an architectural distortion. It doesn't really matter if it's separate or associated, right? You just know what terms to use, or non-mass lesion with some cystic changes, which is benign, or some ductal changes with microcalcifications. Well, then you know that that's going to be malignant. So you put it together. As one of my former teachers and mentors used to tell me, and I'll never forget, back in the early days, you make the B-Rads work for you, because it was like calcifications. Well, are they like amorphous? Are they punctate? I'm not sure. Well, she's like, well, if you think if you think it's malignant, you make it work for you, and you pick the terms that are going to reflect the fact that you're going to recommend biopsy. So it works for you that way. But it can also work for you when you're not quite sure what to do. Then you go through it and then it leads you down that path and says, oh, okay, this is going to be benign. So you can use it both ways. But I think we're going to learn more about all these. As we use it
It's
more,
like,
questions are going to come up. And that's really why the Bi-Rads has that, question and answer section in the, for each part, commonly asked questions, FAQs, and it's constantly updated as we get more of these great questions.
yeah, sure, it's still like work in progress, right?
Yeah, that's the benefit of the electronic version, but they will update those questions. I mean, they don't want to do it too often, but they know these questions will come up for all
Okay,
modalities.
so we have one last questions about axillary lymph nodes. So if you are going to put like to conclude like they are suspicious of bi-Rads 4, should you include A, B, or C, or just 4?
Oh,
If you only see like the suspicious lymph nodes, I guess that's what uh,
I
they are
see.
asking.
It should be Bi-Rads for A, for B, or for C.
Yeah.
First of all, the subcategories are considered optional in the Bi-Rads. Okay. I think they're good to use, but technically it's an option. And in the United States, we have legislation. So we actually don't report that because our legislation, our law says it has to be Bi-Rads 4, 5, 3, 4, 5,
Mhm.
1, 2, 3, 4, 5. So we do not formally report for A, for B, for C. I just have to clarify that. And so in our new reporting system, in the background, we put for A, B, C, but actually the actual report says Bi-Rads 4. So if we want to get the data, we can, but because we're following the United States law. Okay, so back to the initial question. I think it also, you can tell. So I think you can use for A, B, and C for lymph nodes. Now, again, there's Bi-Rads at the lesion level and Bi-Rads at the study level too. So, if you have a lymph node with a big abnormal cancer, you could do Bi-Rads of each lesion, but you still have to have one study, one global Bi-Rads for the entire mammogram, ultrasound, or MRI, or a combined Bi-Rad. Sometimes we'll do that as well. But if you're just looking at the ultrasound of a lymph node, okay, you can have a very cystic appearing lymph node with no fatty hilum. And if you can have cortical disorganized flow, not that normal, that's to me, very, very suspicious for malignancy. And I would call that a 4C. But if you have a lymph node, say, for example, you have a lymph node with a reniform shape, normal vascularity, and a cortex that's like 4 or 5 millimeters, but it's abnormally thickened, that would probably be a 4A because that could still be reactive. So I think you can do that if you want to, but again, it's an option.
Great.
Probably better to do again to try to be more specific and to learn, but that's how I would answer that.
Great. So thank you very much, Dr. Hooley. It was a very interesting class. I'm sure we all learned a lot, and we will be looking forward for the new update virus edition. So, and maybe then we'll ask you for another conference because we're going to have many new questions and
Yeah,
doubts
exactly.
about it.
Yeah, it's my pleasure. Thank you very much for this, and I really love the questions, and I think they were great questions, and I think this is great learning for everyone. So I appreciate the invitation. It's good to see you. Thank goodness for Zoom. And I hope you all have a nice evening.
Thank you so much. Y para nuestros asistentes, recordarles que tenemos el Congreso de CIVIM este año en Guadalajara, el 17 y el 18 de octubre. Tenemos reconocidos invitados internacionales para que puedan revisar el programa en nuestra página web. Y en la siguiente les muestro, no sé si es, bueno, hay una convocatoria de trabajos científicos donde también pueden mandar las investigaciones que están haciendo para poder presentarlas durante el Congreso. Y finalmente, invitarlos a todos a ser socios a través de la página civim.org. Deslizan hasta el final y está esta opción para hacerse socios. Y a los que ya son socios que han cambiado de email, por favor actualizarlo. Esto lo pueden hacer directo al correo o a través de la misma plataforma. Y también los invitamos a seguirnos por las redes sociales. Tenemos Facebook e Instagram, donde vamos publicando casos y revisiones de artículos y noticias de mama para que nos sigan a través de las redes sociales. Así que, Marce, no sé si quieres decir algo o
Thank
una
you
cosa
very
más.
much again, Regina. It was a pleasure to be here and have this wonderful lecture from you. Um, y bueno, muchas gracias por la audiencia, fue un récord, hubo más de 300 personas conectadas, así que muchas gracias por su concurrencia y los esperamos pronto en un nuevo webinar. Así que muchas gracias, Carla, por tu ser anfitriona de este webinar y esperamos que nos veamos pronto, ya sea by Zoom o por en persona en Guadalajara. ¿Mm? Así que buenas noches a todos.
Gracias a todos. Buenas noches. Thank you, Dr. Hooley.
Buenas noches.